Think that biomarker testing, broadly speaking, is really, really important for all of our patients. Specifically for determining whether there's defective mismatch repair, our testing methods are actually pretty good. There's a couple of tools and techniques that we use that are different, but really get at the overarching question of whether there's defective mismatch repair. One example is staining for protein expression. Another example is sequencing DNA or using a technique called PCR. So the actual techniques themselves are fairly robust, but there's certainly a gap in simply ensuring that all patients have quick, timely reported results for all biomarkers. But of course, mismatch repair is very important because it can directly change the management plan for what is the best therapy for a given patient. Absolutely. So, we know from patient populations that do have advanced disease or stage 4 that there's been very impressive activity for using immunotherapy against these cancers. It's a common next step in the world of oncology to take something that's working in the stage 4 space and to say, hey, will this same strategy work in a stage 2 or 3, or sometimes we say a locally advanced stage? This is really important because if we can increase cure rates for patients, it's a game changer. There's been several studies, mostly at the phase 2 level, that have shown neoadjuvant immunotherapy has had very impressive response rates in locally advanced disease settings. It can be up to 70% of the time that we see what is called a pathologic complete response. What that means is by the time the patient goes to surgery, after they've completed whatever preoperative therapy that they did, that the pathologist looks at that tumor specimen. And what we really like to see is all cancer cells have died. And it's referred to as the tumor bed because no live tumor cells are seen. Unfortunately, the reality for most patients is that neoadjuvant therapy does some benefit, but rarely, or I should say the minority of the time, we get 100% death of all the cancer cells. So neoadjuvant immunotherapy has really pushed that limit from maybe the low 20% to north of 60, 70%. When a patient's tumor has defective mismatch repair, which we classify just as you said, dMMR, MSI high, that biology is a distinct biology that typically leads to a better prognosis. It also informs treatment selection. And as I discussed earlier, if if a provider takes that information and selects immunotherapy, that patient is poised for a much better outcome than perhaps if they did not get immunotherapy and relied on a more conventional chemotherapy strategy. So overall, knowing the status and then leveraging it in treatment selection will lead to significantly better outcomes for patients. I often have a discussion with patients that there's really 3 pillars to cancer therapy. This is broadly speaking. I summarize that as surgery, radiation, and then the third bucket is what I call systemic therapy. And under that bucket, that could include chemotherapy, immunotherapy, or targeted therapy. The point is that for patients that have a chance at cure, which typically means a surgeon removing all of the cancer, we put all of those tools together, or some combination of them, to shrink the tumor and ensure that all of it can be removed to achieve a cure. Now, for a patient with stage 4 disease, which by definition means the tumor cells have spread to a distant site from where they originated, unfortunately, by definition, we're not able to cure or eradicate that disease. And our goals of therapy are different. Our goals are to control that disease, hopefully shift it to more of a chronic disease that's well controlled, and that the patient can continue to live their life and enjoy a good quality of life. So that's one of the fundamental differences between treatment of locally advanced disease as well as advanced or stage 4 disease. It's very, very important to increase testing frequency across the board. Most academic medical centers are doing what is considered standard of care testing. And I would actually say that most sites in the community are as well. But there is more variability in getting the testing completed than patients deserve. There's also delays. Often a patient will get a biopsy outside of the system that they'll end up getting treated for their cancer within. And there can be delays getting that biomarker testing completed and then those results reported to whichever cancer center is treating them. And these delays, I mean, there's real logistical challenges, so I don't want to minimize those challenges, but fundamentally, patients need this information so providers can give them the best treatment plan. And for that reason, we really do need to improve biomarker testing across the board and the efficiency of it. I think that it's very exciting to think about the idea of an organ-sparing approach. And what that means is for our patients with locally advanced disease, which is stage 2 or 3 disease, right now surgery is a critical component to achieving a cure. But for deficient mismatch repair or MSI-high tumors, if we're seeing robust responses to the point that the cancer might be eradicated and that patient might not actually need a big surgery, that would be a game changer. And so my immediate thought as an answer to your question is that there are studies that are beginning to look at patients that achieve a complete response to immunotherapy alone and whether they can do fine without getting a big surgery involving taking out the esophagus or taking out the stomach.